Okay, so good morning, everyone, and I would like to again welcome all of you to our mask ultrasound. A very, I would say, his reputation always precedes meeting him, and for a long time, I've been wanting to really see him personally, but I cannot just catch him because he's busy and he's actually everywhere. And so eventually I was able to catch him here on the internet and online. So I am so happy to have Dr. Brad Fullerton. He's a PMNR, and we're so happy that we are on the same specialty. He came from Texas, and he's also a member of the American Academy of PMNR, and also other society like Argentine Association of PMNR, University of Wisconsin, American Association of Orthopedic Medicine, and Texas Medical Association, University of Pittsburgh, Walter Reed Army Medical Center, and National Institute of Health. And he is always at the forefront of regenerative injection, especially in prolotherapy, since 1999. So I'm so happy to welcome our speaker for today, a very excellent colleague, and he has started all this stuff in prolotherapy for such a long time. And I would say he's an expert in this field, and I'm very happy that we can join him today in our mass courses on Zoom. But before we begin, let's just pause for a moment for a short prayer. Heavenly Father, we thank you for life. We thank you for this opportunity that we can begin another series of lectures for this year 2021 with Dr. Brad Fullerton. We would like, Lord, to ask for your presence to be upon us, that we may discern and understand his lecture and help patients more, especially in their pain, in their problems in musculoskeletal system. Thank you for your grace and for your forgiveness. In Jesus' name we pray. Amen. So, Dr. Brad, welcome. And we're so happy to have you today in this lecture in mass coaches on Zoom. So, Dr. Bradley Fullerton.
Thank you. All right. Oh, here's our beginning slide here. I'm going to minimize myself there. Okay. So we're going to talk about biotensegrity and biotensegrity-based diagnosis, especially of fascial injury. So one of the most difficult things about prolotherapy is deciding where to treat. And so I like to use dynamics in the diagnostic process to decide where is the optimal place. There we go. So this is a picture I took at the first prolotherapy research meeting back in 2005 at University of Wisconsin. This is Jeff Patterson, who many of you know, I'm sure. Many of us learned prolotherapy from him, and he was an incredible person. Who was involved not just in medicine, but many other causes that he's passionate about. And it was a big loss when he passed back in 2014. He started the Prolo Research Meeting along with David Robigo, and you'll recognize David's name from many publications in prolotherapy, along with Dean Reeves, who's not in this picture, but was at the meeting. And then the last person there is Michael Yelland, who's from Australia. And in 2004, right before this first prolotherapy meeting, research meeting, he had published a long and large, lot of work study on prolotherapy in the lumbar spine. And the conclusion of that study was, in chronic nonspecific low back pain, significant and sustained reductions in pain and disability occur with ligament injections, irrespective of the solution injected or the concurrent use of exercises. So, of course, this was originally published as a, quote, placebo-controlled study, and that was unfortunate wording because there was no placebo in this group because all of the participants received injection into ligament. And So for me, the conclusion of this study was that they're finally getting to the right tissue in terms of a chronic low back pain study, and not focusing so much on the disc and the facet joints, more on the connective tissue, right? So those of us who do prolotherapy certainly have that bias in looking at what causes chronic low back pain. And most of us learned from George Hackett's book, and these are some diagrams from his book. These are diagrams that Jeff Patterson actually shared with me. They're the original color drawings from Hackett. And in the book, they're in black and white. And so I got Jeff's permission to use them, and then in lectures, and then the Hackett Himwall Patterson Foundation gave me permission to use them in an article I published in 2018. So if you get the PDF of this article down here, can you see my pointer, by the way? Are you able to see that?
Yes.
Yes, doctor.
Okay, yeah. Great. So if you get the PDF of this, you can have it'll have a color copy of these drawings, which are really useful in terms of referral patterns for ligament relaxation or injury in the sacroiliac region. But in some ways, I'd like to challenge this, because I think one of the things that I've learned over doing prolotherapy over a couple of decades now is that chasing the pain generator can sometimes lead us the wrong way. So which can be a little disheartening to hear, but we've certainly all run into this, I think. Sometimes if you treat the pain area and you think you know the pain generator, you end up flaring people up more and not getting them better. So one of the objectives I'd like for this lecture is to recognize that when we ask what is the pain generator, we tend to limit our understanding of what the pathology is about. I learned that, of course, from biotensegrity principles, which will apply to anatomy, biomechanics, and physical exam today. And I'm hoping that we will understand muscles more as a part of a dynamic fascial continuity rather than as individual muscles. And then as a specific example, I want to talk about the serrati fascial plane and its involvement in scapular pain and dysfunction. So to kind of narrow it down to one area somewhat. So when we approach patients, we all have our perspectives, right? So this is the way I felt in medical school. I would go sit in a lecture in the late 1980s and listen to a PhD describe the detailed workings of some body system, physiologic system, and I would be lost because I would have no perspective. They'd be describing all these details. So when I present this live, I like to ask, where was I when I took this picture? And of course, the answer from the audience is, how can you tell? There's no way you can tell where you were standing when you took this picture. But if I add some dynamics to this and some perspective, some people will start to recognize this famous painting, which is in the Art Institute of Chicago. George Seurat, is that right? Anyway, it's a very famous, it's a huge painting. It covers an entire wall in one of the rooms there. And when you see it from a distance as you walk in the room, it's a beautiful presentation. And if you get right up next to it, it's just a blur, like it started with. So I like to make the analogy to this wisdom of Lao's. What he saw as one was one, and what he saw as not one was also one. In that he saw the unity, he was of God. In that he saw the distinctions, he was of man. And all of science, of course, is making distinctions and narrowing things down to smaller and smaller elements to be studied with some level of reliability to understand things. But ultimately, by looking at these detailed parts of the body, we can never understand the whole. And so we need to oscillate between these viewpoints as much as possible. And the tensegrity model is something that, for me, helps me to be able to oscillate between these viewpoints. Graham Scarr, who's standing here, and he's working with a multi-bar mechanism here at a biotensegrity interest group meeting. So he says the value of the tensegrity model is that it provides a better means to visualize the mechanics of the body in the light of new understandings about functional anatomy. This is Steve Levin, father of biotensegrity, orthopedic surgeon, and this was 2 years ago up at Steve's house. Graham was hanging out with him for 2 weeks working on a project, so I got to go hang out for a couple of days and happened to have a snowstorm in the DC area. It was really a peak moment for me. It was a lot of fun. So what Steve and Danielle Martine say in this article is that we need to think of movement not as bending of hinges, but expansion, repositioning, and contraction of tensegrities. So when you look at this frog and you think about how this frog moves to capture its prey, it's very illustrative of that expansion, right? So this frog isn't bending hinges at certain points. He's expanding his entire body towards his prey, and the tongue is going along with it, and that occurs in 0.07 seconds, 5 times faster than the human eye blink. It's helpful to see the entire visual, and whenever I look at this, I think about in 2005, I went and did a talk at the PM and R department at the National Institute of Health, and to talk about ultrasound and to talk about tensegrity. And afterwards, there was a PhD speech therapist who we were walking down the hall, and she said, you know, that's got to apply to the tongue. I've always been taught it's a hydrostat, and it's never made sense to me. It's a tensegrity structure. That must be how it works. So that was 15 years ago, almost 16. And it's really true. It has to be a tensegrity structure. So how do we apply these kind of vague, global kind of concepts to patients? So here's a patient of mine who has a deficit in this expansion, repositioning, and contraction of tensegrities. He has an intention tremor. So you can see his hand just vibrating, and his complaint that brought him in is scapular region pain. But he's also had this tremor for a year. He's had this pain for many, many years. And this tremor has started very gradually and has gotten worse and worse and worse. And now he's like, he can't hold a cup of coffee to drink in the morning. And because of tensegrity, on exam, I was focused in on an area. And so I apply a little pressure, light pressure, 3 fingers at that location right there. And then he doesn't have the tremor. Now he has a very little tiny bit of a tremor there. But so why does he seem like he has a neurologic disease? And why does he have pain? And why does a light pressure right there resolve his apparent neurologic problem? So if we think about tensegrity structures, they are closed, stable systems of 2 forces, tension and compression. And the structural integrity of the structure is maintained through continuous tension, discontinuous compression. The system stores energy as pre-stress in the tension elements, and you end up with maximum stability, minimal mass. And one of the most important things, number 5 there, instantaneously diffuses outside forces through the entire structure. Now, instantaneously, that's not a scientific term, right? But it's the most rapid communication in the body. And then an oddity of tensegrity structures that has to do with chirality and this kind of jitterbug motion that Steve Levin talks about is that tensegrity structures naturally produce oscillations, and they do not dissipate the stored energy. So you get movement without energy expenditure. So this is where tensegrity started. Kenneth Snelson's sculptures, which you've seen, I know, from Dr. Vong in her lecture. This is the Snelson needle that used to be at the Smithsonian Institution in DC. They've done a revamping of their sculpture garden, and it's not there. There's talk of putting it back up there, but it's not there right now. So when I tried to summarize tensegrity and how it applies to anatomy and biomechanics in the shortest way possible, this is what I came up with. Bones float and fascia communicates. Those are the 2 most important things to keep in mind. And so really the frame of the body is not the bones, which we all tend to think that's the frame, the physical frame. The physical frame of the body is the tension in the soft tissues. It's the energy stored in that tension. So the bones are the easy way to think of a frame, but it's not accurate. As I tell patients every time I see a new patient, I tell them, we all start as soft-bodied organisms, as an embryo. We don't have any bones, and yet we're stable and we can move. And the fascia is what develops first, and the bones develop within that continuity of fascia. The context of the development of the bone is the fascia. So the importance of this stored energy as pre-stress in the tension elements. When Kenneth Snelson is putting together this structure, the Easy Landing installation in Baltimore in 1977, it's still standing there in Baltimore. And some of the energy that he put through his muscle from him eating in the days prior to this, he stored by tensioning these cables one by one in an organized way until they were completely balanced and locked in place, and all the forces were stable. And that energy that he put in there is still there all these years later. So what this does then is create an instantaneous transmission of forces through the entire structure. So here's Buckminster Fuller, who came up with the term tensegrity after seeing a Kenneth Snelson sculpture of floating compression. And one of the ways he applied that in architectural terms was in developing the geodesic dome. So if Bucky here stands on top of this dome, the dome doesn't deform right under his feet. The entire structure shrinks. So the forces, the whole shape of the structure changes because of the force in one location. So again, the example I use, which is a little bit stretched, but real, if I squeeze my earlobe, my toe changes shape instantaneously as I do that. And I think that's part of what body workers and osteopaths feel when they're feeling things like in craniosacral therapies, that they can feel what's going on in the entirety of the body by touching, holding, and feeling in one location. So these oscillations that are created without dissipating stored energy. This is a sculpture that Steve has on his porch. So if I flick this with my finger, put a little bit of energy into the system, it continues to oscillate there. And yet the energy that's stored in those cables, those little wires, doesn't dissipate. You can do it over and over and over again, put a little energy into the system, but it continues to move on its own without needing more energy. And that's a lot of what happens when we walk. So the fascial system in the thoracolumbar fascia, with the crossover pattern of things like latissimus dorsi coming from one side, perfectly aligning with the glute max on the opposite side, you've got a tensional system that as you swing your arms and your legs, you don't need to spend as much energy to stay stable and move. Now, typical pictures like this, again, mislead us from understanding this at a deep level because they show us the bones and then they attach the muscles to it and they put the skin over it, which is not how the body develops or how it works. And these muscles are not things that pull on bones. So we'll get to that more in a minute. So we like to think of the tensional elements in the body as the fascial system, which Carla Stecco and Robert Schleip did this article in 2016, which helps us differentiate an anatomic definition from a more practical functional definition of fascia. So if we're naming a particular fascia like the serrati fascia, then that would be a sheath, sheet, or other dissectable aggregation of connective tissue that, quote, enclose or separate or attach muscles or other internal organs. It's an anatomical definition, and really it's named just to improve communication between researchers and physicians who are operating on things. That's the main reason we have these anatomically named fascial systems. When you have a body worker, someone who's coaching, touching the whole body, they like to talk about the fascial system, which is really the functional aspect of the larger fascial net, a network of interacting, interrelated, interdependent tissues forming a complex whole and all collaborating to form a movement. So when we want to look at the fascial system, we can't narrow things down too much too quickly. We have to look at the whole and how the whole is moving. If we're thinking about scapular movement, this is the way we traditionally learn scapular movement, and this is very helpful. For instance, this is one of the most helpful diagrams. If you picture the scapula and the upper to middle part of the trapezius pulling on the acromion, basically, tilting the glenoid up, the lower part of the trapezius pulling on the medial scapular border, pulling it down, and then the serratus anterior pulling on the inferior angle of the scapula forward, then you get this scapular elevation, rotation, movement, like reaching up for something. So that's helpful in as much as it goes, but it doesn't explain what happens with patients. So this would be anatomy and biomechanics uninformed by biotensegrity. Here's another example. So if you get scapulothoracic anatomy problems and snapping scapula syndrome, so you get all this crunching below the scapula, which we all see just about every week if we do general musculoskeletal practice, somebody will present with some of these symptoms. And I find it humorous to read surgical literature sometimes because they'll say things like this: non-operative management of symptoms is the first line of treatment. So in other words, all non-surgeons can do is manage symptoms. The only way to treat the pathology is through surgery. So the pathology is the bursitis that's developed. But for me, the pathology is the abnormal dynamics that have been going on for years that have created the abnormal bursa deep to the scapula. So rather than going in and operating on it or injecting a steroid into it, figure out why the dynamics are off. So if y'all want to see another lecture and also learn more biotensegrity, you can go to Biotensegrity parties that the Levin Biotensegrity Archive puts on. I did one in July on this topic and show some other videos that you may find useful. You can also sign up to join these. They're still doing them most Fridays, and the topics vary widely, but always have to do with biotensegrity. So another option. Okay. Movement and control of movement. I love to interact with my audience when I'm lecturing, so I'm still getting used to these Zoom meetings. But I don't know if any of y'all have seen this decerebrate cat video on YouTube, but you can find it. And nobody knows exactly where this was done. They think somewhere in the Eastern Bloc, Russia, one of the countries near Russia. And this used to be a standard research model for understanding neurology. So if you decerebrate this cat and then you suspend them through these little cables onto a treadmill and start moving the treadmill, then you'll get a walking pattern. And if you increase the speed, you'll eventually get to a trot pattern of movement. And if you keep going, then you'll end up with a running movement. So without a connection to the cerebrum, all of these muscles still work together in patterns. And so the research model is focused at how does this work neurologically, right? So the control of locomotion in the decerebrate cat. There's many articles, various research methods on this, and they focus on things that I learned back in medical school and have since forgot, like mesencephalic locomotor region, the medial medullary reticular formation, ventrolateral funiculus. And anytime I'm thinking stroke, I have to go look up these structures again to try to remember them. But that's where the focus is, because control of movement is neurologic, right? That's, again, what we default to unconsciously. But again, that idea is based on the fact that we think these bones are the frame of the cat's body. And if my contention is that if you were to cut this thoracolumbar fascia on one side, then the cat would run off to the side or not move normally, not because you changed their neurology, but you changed the context of the entire neurologic system, the fascial system. And this fascial system is incredibly complex and can work as a kind of computer on its own. So listen to this robotics professor.
Discovery Channel filming. we made a successful launch at 1:52 p.m. of the large Hex Runner, and it went to world record speed for a robot, demonstrating stability and the concept that stability at these speeds is geometric, not a matter of traditional control methods.
So with the Fast Runner project, we're trying to show that it is indeed possible to do really fast, efficient, graceful running using very little feedback. With most running and walking robots, we have a lot of sensors, and about 1,000 times a second, we read what the sensors are doing, do a lot of computation to figure out what the actuator should be doing, and then send a desired current or torque or command to the actuators. And we have to do that really quickly or the robot will fall down. As opposed to that, with the Hex Runner and the Fast Runners, everything is done mechanically using springs and linkages. All of the feedback mechanisms happen physically. So instead of having to do a lot of computation and have a lot of sensing, as you squeeze the throttle on your RC remote, it speeds up the motor, gives more power to the motor, and just based on the dynamics and the geometry of the mechanism, the robot's stable.
Yeah. So they're saving energy, decreasing the amount of computer input they need to cause movement by changing the shape of the structure and the linkages and springs and things. So when you create a robot that looks like a person because you're basing that appearance on the bone structure, it takes a lot of energy to move the robot and to keep it stable. When you start changing the way you make a robot into more of a tensegrity type structure, you need less energy. And you get better stability. So all the feedback mechanisms happen physically. So we tend to think that control is neurology, and actually most control is the structure of the fascial system. It's the structure itself that is processing the information, force, and direction, performing its own logic computations that were previously attributed to the central nervous system. That's Steve Levin, Susan Lowell, and Graham Scarr, who wrote this article in 2017, and they refer to this more technical article about multi-bar kinematic mechanisms. So if we think of all of our movement as this incredibly complex multi-bar closed kinematic mechanism, we're much closer to understanding how we control movement and how old injuries lead to current pain and other symptoms. So if we apply biotensegrity ideas to anatomy and biomechanics, we realize the most rapid communication in the body occurs via the pre-stress collagen fibers of the myofascial system, not the neurologic system. Muscles are not structures that pull on bones to cause movement. Bones float in a variable tension network consisting of muscle and fascial elements, and that fascial continuity provides passive tension and stored energy in the form of pre-stress. The muscle fibers then are things that fine-tune movement, but they don't provide the main energy of movement. The main energy of movement and control is the continuity of the fascial system. So that's why we can move around with such low energy needs, and why old injuries and spasming muscles make us use more energy and feel more tired after we've injured our low back, right? Because we can't use our fascial system as well. One reason, obviously. So bones move when the tension around them changes. So this to me helps explain why I always had as a kid, I would see snakes slither around and try to imagine how the bones were being pulled on, and I couldn't get it. It's like, how do they move the way they move? Well, they move through tensional continuity. So again, clinically, when you see somebody, if all these things are true about tensegrity and that we are tensegral organisms, then the tensional continuity is prime. And the history is finding where there's a loss of pre-stress. What are the old injuries that have added up to the symptoms? What are the old repetitive stresses that have added up to the current symptoms? And those symptoms, a lot of them are muscle hyperactivity, but they can be uncoordination, like the gentleman's tremor. So when you have hyperactive muscle, it's not necessarily because the muscle is overreacting. It's that the muscle has to overreact in order to stabilize something that is unstable. And it may not be right where the muscle's hyperactive. It may be pulling on a fascial plane that's been injured somewhere else and compensating for it. So we have to use dynamics to find the loss of tensional continuity in the myofascial system. And then we get to prolotherapy or regenerative treatment, focused not necessarily where the pain is, but where the loss of tensional continuity is. Again, it's a tall ask, a high ask to figure all this out. But for some reason, I'm obsessed with understanding every little fibrous connection in the body, because it's amazing the things that you can get better that previously you couldn't. So again, history is loss of pre-stress and then muscle activation. So here's a gentleman, we're not going to go into too much detail in his case, but I'll show you the potential for what I'm talking about again. So I asked him to put his arm out, and he doesn't put it all the way out. And then I push, like doing a speeds test, and he cannot hold it up. Obviously, he is much stronger than me, and he should be able to hold that up, but he just can't. And he doesn't have any pain doing it. He just can't hold it up. So we get him into more of the empty can position and test again. And he's actually even weaker and can't resist. So, well, this obviously is the reason. 6 months earlier, he had a weightlifting accident where he injured his shoulder, subluxed it, and it popped back in. And now he's got this bone marrow edema and cartilage injury at the posterior superior part of the humeral head. So it's easy to say that's why he's so weak, right? It must be pain signals from here that are nociceptive signals that aren't fully conscious because he's not perceiving pain. But if he has a loss of pre-stress somewhere in the system and we compensate for that loss of pre-stress, we may be able to find there are other things contributing to his dysfunction. So this was at one of my workshops a couple of years ago. And so I had somebody attending the workshop to apply a little stress right there. And then suddenly he's 5/5 strength and I can't break it. And then we do it again in the empty can position, same thing. So, okay, it's not the dislocation, but did this contribute to the dislocation? Because this injury occurred about 10 years earlier when he was in a car wreck. And of course, we wouldn't have found that out if we weren't focused on a loss of pre-stress from old injuries as something that's changed the dynamics of the system. So we don't have time to go into it all, but he had injured his abdominal wall as well as how that blends with the external oblique and the serratus anterior in this location, along with latissimus dorsi. And I go into more of that in that Biotensigrity party lecture if you're interested. But let's talk about the anatomy of that location that we're putting pressure on. Now, this is from I forget the name of the program, Complete Anatomy or something like that. So basically where I'm putting pressure is about right here. And this is the serratus posterior inferior muscle, depicted as something that originates from these posterior spinous processes and inserts on these ribs. And so what it does is pull the ribs down. That's how it's defined, what its function is. But I don't believe that's the main reason we have these muscle fibers here. And this is not shown accurately because there's actually a closer blending between this serratus posterior inferior and this serratus anterior. And there's also, of course, something lying over the top here, latissimus dorsi, that's attaching to those low ribs as well. So if we isolate this serratus posterior inferior muscle and this serratus posterior superior muscle, again, this one now is pulling these upper ribs up and these is pulling the lower ribs down. So they're muscles of inspiration, expiration, and they're accessory respiratory muscles is kind of the way they're defined. But are they really muscles, right? So in Carla Snecko's Fascial Anatomy textbook, what she explains is these two muscles are actually muscle cells embedded in one continuous fascial plane that is bridging this entire area. So it's attached to all of these spinous processes. Part of it has muscle fibers in it. Part of this does not. So this muscle does not end here. it's continuous with that muscle. And all of these fibers are going that direction. And this is the serrati fascia. So what it does in terms of Carla's perspective is it provides a gliding plane for your scapula. So the scapula will then slide on this fascia. And if you get adhesions in this fascia, then you break those up, and that helps improve the symptoms, which is true. But there's more to it than that. So let's go to the embryology of this. The limb buds start at about 37 days, and they start as this grouping outpouching away from the midline. And our arms then become connected to our body, not here, but here and here. So this pectoralis major muscle is one that starts as part of the limb bud. It migrates to this position at the midline and actually blends with the contralateral pec major. Same thing happens with the trapezius. Same thing happens with the latissimus dorsi. Rhomboid here, subscap, serratus anterior, attaching to the ribs. So your arm is not attached, of course, at your glenohumeral joint. It's attached to your ribs, to your sternum, and to your spinous processes of your back. So that's where the arm is. So that kind of awareness of fascial anatomy and how things develop can lead to things like this. This is a stock photo from University of Texas. So this is not my patient, but this was an elite level teenage volleyball player that I saw years ago. And she had had 2 years of anterior shoulder pain. This is her pain diagram that she marked. And she had painful palpation to the rotator cuff tendons. So immediately prolotherapy, you go here and start injecting with some dextrose. Her O'Brien's and empty can, though, were positive. She had pain, weakness, giving way. And so when she had seen an orthopedic surgeon, they'd gotten an MR arthrogram, which did not show a labral tear. It showed some bursitis, subacromial subdeltoid bursitis. So if we pull back, again, get the broad perspective of a biotensegrity, we have to look at the whole posture, right? She has really tight-looking thoracolumbar paraspinals on the right side, right near the thoracolumbar junction. And if we do detailed palpation, like we learn in prolotherapy, we realize that her lower thoracic spinous processes are tender, but only on the right side of the spinous process, not on the left side. So I can push over here, no pain, slide over here. Oh, that hurts. So if I have her sitting and I'm doing this O'Brien's empty can or Speed's empty can, O'Brien's, then before she moves her arm, if I get her arm resting, and then I apply a little pressure just to the right of the thoracolumbar junction posterior spinous processes, these tests turn negative instantaneously and she has no shoulder pain. So I'm putting pressure to the right side of that box, right about there, not on the spinous process, just to the side of it. And again, it's not firm pressure like you're trying to elicit some pain. You're just putting a little pre-stress into that fascial system. Well, this is what her ultrasound looked like. So this is the left side of her body at T12, the spinous process, midline here, midline here. And let's look at these layers. So that's the dermis. That's the adipose tissue, which contains the layer of superficial fascia. And that's the first layer of the deep fascia, or the investing fascia of the muscles. So that, in this case, is your arm. Those are fibers that started as part of your limb bud and are connected to your latissimus dorsi and your lower trapezius. And then just below that layer, there's a little line right there that you can see on this side. That is your serrati fascia. And look at it over here. It's not quite as organized. Now she's 16, so she's pristine on this side, but this side where she's been hitting the ball for years is kind of stretched out. And then if you go to the layer just below that, what is this compared to this? This looks like a taut sail on a sailboat. This looks like a loose sail on a sailboat. And I use this analogy with patients all the time. If you have a sail and you loosen the ropes a little bit and put a little bit of laxity, looseness in it, you get a breeze and it flaps and you get no movement in the boat. You get a strong breeze, it'll tension the sail, and then it'll start moving if the breeze is strong enough, if the wind is strong enough. But if you tighten all those ropes and turn this into this, then a little bit of breeze creates easy movement. So this is a loss of tensional integrity in the aponeurosis of the erector spinae muscles, and then in the overlying posterior layer of the thoracolumbar fascia, which is basically your arm. So that makes a lot of sense with her sport and her repetitive stress. So if I start pushing on these spots, that's on the left and then on the right, and I think you can see a difference in the compressibility. It looks like there's some giving way in the muscle down here, but this fascial plane is also sliding away from the midline as I push on it. And this one starts to slide and then it stops. And this one slides and it just keeps going. So, and then as I'm sitting there thinking, is this real or not? This is in 2013. Is this really a difference? Am I just seeing things that aren't really there? Then the patient spontaneously says, is that you clicking or is that me? And that was her clicking. And this is where I was supporting that suddenly turned her arm, her positive orthopedic tests into negative orthopedic tests. So what did we do? Well, I used traditional prolotherapy solution, 15% dextrose. And what I've been doing for years to understand this stuff is I will first inject these solutions with lidocaine dextrose under ultrasound guidance at areas that I'm thinking are part of the issue. So we went from, back then I was calling the dorsal fascia, but it's the posterior layer of the thoracolumbar fascia and that aponeurosis that's right below it. And I infiltrated fluid along there, not trying to hydrodissect, but trying to just fenestrate through and put fluid into this three-dimensional networks of fibers to kind of tighten it up. T6 to L2, that's what looked weak to me on ultrasound and where she was sensitive on exam. And then once the lidocaine dextrose is in there, retest and her orthopedic tests all turned negative. And her active range of motion went from limited to full range. So after that response, I was like, well, I think I just want to treat this and not treat your shoulder. And her parents were fine with that. So then we put in platelets into those same locations. And after 2 months of repair time, her shoulder pain stopped. And then a year later, her dad showed up in the office with shoulder pain and said, oh yeah, she doesn't have any shoulder pain. She got a volleyball scholarship and is going to college. That's when you know that you've gotten the right area, right? I tell people we will be positive of the diagnosis once you're fixed. Otherwise, I'm always suspicious there's something else contributing. So that's not a traditional diagnose before you treat in medicine approach, but that is a very scientific approach because it keeps all our options open in terms of differential as you move through a process of diagnosis and treatment. So let's get back to our patient that we were introduced to originally. Again, he has a deficit in the tensegral system somewhere. We've confirmed that part of it is at least in the similar area as our weightlifter that we saw earlier, because we can get rid of the tremor there. So if he has a weight in his hands, he seems to have even more. This will tend to set off his pain. Look at his triceps. What's going on there? And then
I'm noticed if I tense my back,
he's noticed that if he tenses his back, his tremor's less. Well, that's his latissimus dorsi, right? Which feeds into that fascial system. And actually, in Carlos Stecco's book, I don't have a picture of it in here, but there's a myofascial expansion of the latissimus dorsi to the brachial fascia overlying the triceps. So when your latissimus dorsi contracts, it's not just pulling on the front of your humerus, it's tensioning the fascia on the triceps, which is part of what helps elevate and suspend your brachium in space. And if you don't have this adequate pull, you don't get enough tension in that brachial fascia as well. And we think this isn't active when you're lifting your arm, but it's very important in stabilizing. So you're always co-contracting muscles. You can't isolate one muscle and test that. It's impossible. I wish I could stop and take questions to see if people are still oriented and listening, but I'm just going to keep barreling through. Okay, so where I'm putting pressure is along here. These are the serratus posterior inferior fibers, and they're coming across. And what Carla has shown is it's not only a continuous fascial plane all through here. The outer layer of the fibers actually continue on. Part of it attaches to the ribs, but it continues on, and it becomes the deep surface of the serratus anterior. So that's all one continuous fascial plane flipped on itself. And of course, what does it do up here as it approaches the scapula? On the undersurface of the scapula, it actually is the undersurface of your rhomboid muscle. So it's all one complex that's controlling movement. So this is our tremor patient, and where he marked his pain, big old X, his whole shoulder blade practically just to the medial side of it. This is his pain with exercise. And his history involves a couple of big traumas at younger life. He broke his collarbone wrestling in 1972. He also got T-boned and broke the same clavicle in a car wreck, but then didn't really have any problems until 2011. And actually what he noticed first before he got any shoulder blade region pain is right hip pain, really kind of right low back iliac crest region pain. And he found that he was changing the way he ran just kind of naturally, and eventually his hip pain went away. And then about 3 years later, he started deadlifting some bigger weights and doing squats and running more. And then in the fall of that year, he started noticing pain between the shoulder blades. And the pain got worse and worse with running. And then he started getting spasming. And he just said, you know, I had never really injured that area. I think it's because I'm using my mouse at work. And it's the desk work that's causing this problem. Obviously, I thought differently, right? So later, as we keep pummeling with questions, one of the things you have to do is keep asking questions about prior stressors. He's like, oh yeah, I've done martial arts for decades. So he's been thrown on that right scapulothoracic region over and over and over again. And that's a repetitive stress that we need to take into account. So the things that he's done in the past that have helped some have been a little bit with steroid injections. He had some, I think they just did local muscle steroid injections. And then trigger point injections, which would help, but were very temporary. And let's see, his testing was pretty unremarkable, except with his O'Brien's. He had a tremor when he was trying to hold his arm up. And if we did speeds from 90 degrees abduction, this is what I call it, he was definitely weak. And it would improve if I supported that aponeurosis of the erector spinae at the thoracolumbar junction, kind of like the volleyball player. And then, of course, we could get the tremor to go away by supporting in the region of the serratus posterior inferior here at the ribs. So if I put a probe there at T11 and I'm compressing on the right side, there's the spinous process. Again, like the volleyball player, you can see a clear difference in the laxity of that posterior layer of the thoracolumbar fascia and how much movement. This group of muscle here is actually part of longissimus, and then the small deep ones here are multifidus. And these longissimus fibers stay locked in place on that side. On this side, they glide away, and you can see all this heterogeneity in the blending on the right side and more compressibility. So a lot of what I say on ultrasound reports that I do is the right aponeurosis of the erector spinae and the longissimus and multifidus fibers are more heterogeneous, hypoechoic, and compressible on the right than the left. And the longissimus translates laterally with compression on the right, but not on the left. So that's the kind of things I'll report, which again are not scientifically validated, but I'm in the midst of collecting data at T11, T12, and L1 with these types of maneuvers on 100 consecutive patients with low back pain. And we're fairly far along gathering that data. So hopefully we'll have that in the next year or so and have something to say more definitively. But this is an area I find commonly affected in all kinds of patients, upper extremity, lower extremity. It's a central area, obviously, of transition where the diaphragm is in play at this thoracolumbar junction. The mobility of the spine is changing because the ribs are ending and the lumbar spine is. So that's a really important junction that's involved in a lot of chronic dynamic problems, I'm convinced. And I bet all that will become more clear in the future. So if you go down to T12, you see something very similar. Again, it's less compressible on the left side as compared to the right. It's more heterogeneous on the right. This picture, by the way, is from an incredible article by Frank Willard and others, including Robert Schleip, Andre Vleeming, and it's the anatomy of the thoracolumbar fascial system. It's incredibly detailed. You can read it over and over and learn something new every time. And it's in the references at the end here. If you don't have a copy, get it. It's really good. So if we put him in a seated position rather than laying prone in these other pictures and put a curved array probe on him, you instantly know there's something wrong, right? This is the same location. Here's your posterior layer of your thoracolumbar fascia blending with aponeurosis. You can't really make them out with this lower resolution probe. But on the right, what is going on here? Very distorted, right? So there's the probe. And if I put the probe in motion and do a little tilting, again, this stays pretty well defined while I'm tilting, and this changes a lot. So again, more confirmation that there's injury in this location, even if you don't know exactly what you're looking at, right? So let's see what else so then we did some extended field of views on that same area of the thoracolumbar junction going out towards the ribs. So this is an axial slice through the body, and this little echoic structure here is the 12th rib. This is the 11th rib. And then you have layers on top of that. So the first layer is the latissimus dorsi, like on the left side here in Willard's article. If you peel off that latissimus dorsi, then you see the serrati fascia underneath with serratus posterior inferior muscle fibers in it. And that would be this layer right in here, both of which don't have great definition. And that's about where I was supporting when it changed his tremor. Here is iliocostalis, and it's hard to tell on this image where the edge of it ends. But this is an area that if you start scanning regularly, if you take my workshop, we spend a lot of time trying to sort through these layers because, again, this is one of those transition areas where the upper extremity is interacting with the abdominal wall, is interacting with the lumbar spine. And all of these fibers are communication. And if you injure them, you lose communication and coordination between your trunk, your abdominal wall, and your extremity. So if we zoom in on that area, this is the 12th rib on the right side. Here's the 12th rib on the left. And again, if we do our layers, this is latissimus dorsi. This is serratus posterior inferior. And then this is iliocostalis attaching to the rib there. So look at where the rib is in relation to the skin on the right versus the left. Look how unorganized this is compared to this. So the rib is hanging out deep under the skin because this has been injured either through repetitive stress or one particular fall, who knows. There's the labels for each of those layers. And so our first treatment then was doing, go back to that, is doing a similar, this is leukocyte poor platelet-rich plasma. We got 10 cc's of platelets out of 120 mLs of blood. And then we had 5 cc's that we made leukocyte rich. And then we had multiple syringes of traditional 15% dextrose prolotherapy with 0.3% lidocaine. And we started by injecting the right aponeurosis of the erector spinae and the posterior layer of the thoracolumbar fascia from T10 to L2. And the multifidus extending down into the multifidus to L1 because they look particularly disorganized. And then we retested a few things. And what he said was, that's holding really well. And I'll show you that video here in just a second. He still had a tremor when I was testing like speeds. but he was really surprised. So again, my procedures take a long time, and I've designed my practice over the years so that I can do this and kind of be academic with every patient. So we learn things with each patient individually, and then hopefully apply those to broader populations over time. But just treating just to the right of the midline in these structures is the first thing we did. So here's some examples from his procedure. So I'm coming in from lateral to medial, fenestrating through these fascial layers and injecting some as I go, hitting the bone as well and injecting there. So here's all the marks. So I've been going this direction. And then I'm immediately after, no platelets in yet, because that will irritate things, cause more nociceptive signals and inhibit muscles. So now we've got a decent block plus some addition of tensional forces pre-stress in the fibers from the hydraulic pressure of introducing this fluid. So see if you can hear him.
Okay, so go ahead and lift that up. Huh. It's holding pretty well.
It's holding. No, that's really good.
He said, no, that's really good. I said, oh, that's holding pretty well. And he said, no, that's really good. So he hadn't been able to do that in, I don't know, a year or two, hold something steady like that. And this is a few minutes after injecting those locations. So of course, that's confirmation. Yeah, we're going to put platelets there too to try to stimulate more repair. And then we proceeded to the other locations at these ribs where there's injury to serratus posterior inferior fibers, the serrati fascia attaching along here. So you can see this fluid spread into the serratus posterior inferior fibers there. And I'm fenestrating through this latissimus that looked ragged and injecting some as I go through there. This is up at the 10th rib, which also was affected. There's serratus posterior inferior fibers attaching up there. And it's the 10th to 9th ribs where the transition is going from those serratus posterior inferior to the serratus anterior fibers. That's a key location for scapular control. So we did 2 treatments, and his area of pain shrunk. His pain at rest and activities of daily living improved a bit, but with exercise, it really didn't change much. But his tremor was almost completely gone. So from those 2 treatments. So he was very happy with that. So he said he kept trying to run, but it just would worsen the pain still. So that's disappointing. Tremor's 80% gone is what he can walk. Hey, I can walk faster and farther now and I don't get the scapular pain as much. I can do some squats and pulling exercises, but I still get some pain or spasm. I'm not as stiff overall. But now he's gotten a new muscle pain in his lower back and glutes, which of course from his history, this pain predated his scapular pain by multiple years. So again, what we're unwinding his pains that have layered and dysfunctions that have layered on top of each other over the years and decades of multiple injuries. And then he marked his pain in one location, but he came back and said, the pain was over my entire right side, and it's actually better more diffusely. So again, that's patient stories evolve. Any physician knows that over time, right? Which brings us to another application of biotensegrity. And this would be one of the adaptations to a loss of tensional integrity would be adhesion, which we are used to hearing about from hydrodissection world, like Stanley Lamb, hydrodissecting nerves, hydro-releasing nerves. What about hydro-releasing entire fascial planes? So that's Philip Steele. He came and took my workshop back in 2018 and is now going gangbusters with fascial ideas. He's incredible with brachial plexus and cervical plexus ultrasound, the best I've ever seen. I keep trying to learn more from him. I was in Montana last January in his office, and he was teaching me a little fat grafting stuff. And he's great. We want to get him publishing some of his stuff soon. And he also has horses. His wife actually has horses, big Norwegian type horses. And this is what he does at night. So I just had to needle him a little, that he gets to do the scut work when he comes home at night. So I'm using some of his slides, so I had to give him some acknowledgement. So what he's developed, and we, over time, is realizing that this serrati fascial layer is a gliding plane, like Carlos Stecco says. And so a lot of what the snapping and popping and bursal things that are going on under the scapula do have to do with adhesions in this layer that inhibit gliding in that layer. And so this is a prime layer for hydro-releasing. Not because you're necessarily releasing a nerve, although dorsal scapular nerve would be sitting right in here, but because you're going to improve the dynamics of the scapula. And you may reveal more of a patient's story. So let's show you this in Tom Myers anatomy trains. I don't even know how I'm doing on time here. Let's see. 7 o'clock. Yeah, we're still doing all right. Okay, so this is the spiral line that that Tom Myers talks about. That's the splenius capitis going across the midline there, and that's the rhomboid. So as he pulls this rhomboid up, and you look at looking at the serrati fascial plane open up. And of course, you can see the complete continuity into the serratus anterior muscle. And as he releases this muscle, they're going to zoom in on it, and then watch right in here. So he's showing how you lift that up, and you can do manual therapy getting in here. So as he lifted that rhomboid up, you could see all of this tension, right? Let's see if we can play that again. So the rhomboid is flapped over on top of the scapula, and as he picks it up, you see that whole pull right there. So what you have is, I think of it as a tug of war between these muscles. When you are laying prone like this and you need to lift your arm up, you have to elevate your scapula off your rib cage. And you do that not by pulling on the bone, you do that by this muscle pulling on this muscle and this muscle pulling on that muscle. And you end up with a sling that lifts the shoulder blade up off the rib cage. And then you move around. But if there's adhesion here, it feels stuck, and people want to get somebody to put their fingers and dig them up under here. Well, it can feel really good to inject fluid deep to that muscle and get it to feed under this, right? So that's what this is, again, Philip showing how he conceptualizes so he can visualize what he's trying to do. He's trying to get fluid deep under the trap and rhomboid and get it to feed along over the top of these paraspinal muscles so that it gets towards the origin of the serratus anterior, which you can't see because the shoulder blade's in the way. So after talking this through, I went back to my patient's original ultrasound that I did back in 2018. And this is him laying prone. Get you oriented here. Here's the trapezius. This is rhomboid. And this is the medial border of the scapula. And I'm going to have him lift his arm. He's laying prone, relaxed. I'm going to have him lift his arm out to the side, which is a middle trapezius test in some people's world. And what you can see is the grinding of this shoulder blade against the ribs. And that serrati fascia is getting impinged and scraped as he lifts. And of course, he hadn't talked about it very much, but as I did questions, he was like, oh yeah, I got all this crunching and popping under my shoulder blade. Okay. But he's a guy who just pushes through things and doesn't pay attention to them. So what Philip has developed is kind of a standardized way of looking at this fascial plane. Here's the dorsal scapular artery, and you've got rhomboid, and you can see a little bit of serratus anterior right there. This is the medial border of the scapula. That's infraspinatus muscle. And he's pushing and sliding and getting a feel for what's a normal glide in that fascial plane. And then if it's adhesed, it starts to pile up. He calls it a snowplow effect. Like you're not getting as much glide as you should in that region, right? In that layer. So then you hydrodissect that layer. So again, this is my patient that I brought in and did this. And again, this is not gliding well at all. And you can see the dorsal scapular artery and nerve are right in here. So that's probably a lot of his pain, right? So let's hydro-release that fascial plane. So again, this is trapezius, this is rhomboid. So I'm trying to get my needle tip, see the bevel as much as I can, and get it into this plane and start separating these layers out. So again, the thicker the patient, the harder it is, but I'm starting to get some separation. I'm trying to work my way a little more laterally. Maybe that's part of the layer. So I'm getting some of the fluid to feed underneath. And then let's see if it glides better. It's gliding better now that we've gotten some fluid in there. Now there's still kind of a snapping going on here, but it's not dragging as much as it was. But I want to work a little farther, so I take a steeper angle, harder to see the needle, but I can follow the tip intermittently and make sure I'm not going too deep and get some more fluid to flow under there. So that was done in March last year. And then he came back in May. And there's the March version. And then here's the May version. Hey, it's gliding a lot more. And he's like, yeah, it's not snapping and popping as much. I'm like, great. Now we're getting to the ultimate source of this pain. But he says, yeah, the only problem is now I got neck pain, which I didn't have before. So, and then as I talked to him and I realized, oh yeah, he had 2 broken clavicles on this side, car wreck, whiplash. And of course he minimized his pain and he's like, oh yeah, I've had neck pain for years. He just never mentioned it to me. And it hadn't been a problem until I loosened the scapular fascial plane. And now he's feeling the pain up here like he used to feel. So again, this adhesion is probably a way of the body trying to stabilize to relieve pressure on an area that's been injured in the past. Let's see, there we go. So we got x-rays of his neck and lo and behold, he's got grade 1 anterior subluxation of C4 and C5. He's got some advanced degeneration in multiple facets. Actually, he goes, 3 millimeters in flexion, 2 to 3 millimeters. So he's got some instability up there that he was totally unaware of. So then we treat these facets and some other areas around T3 to C7 that were weak in terms of trapezius, rhomboid. And then he says he's been able to back extension exercises for the first time in 5 years. And he started to run a little bit without pain. So that is biotensigrity in action right there. From old injury history to fascial injury to fascial adhesion as an adaptation to covering up one pain area by the body adapting the fascial system to relieve stress, and then using various interventions under ultrasound guidance to solve chronic pain. So I think that's all. Hopefully it wasn't too much information. I'm going to put all the references up real quick so you can refer to those in the future if you want. And that's the last slide right there.
Thank you, Dr. Brad. That was really awesome. Very nice. Can they raise some questions for you to answer?
Yes, should I stop sharing or?
Yeah, you can stop sharing. Yes, right. Okay, any question? If you have any.
Dr. Jim, I have a question.
Uh-huh.
Okay.
May I ask a question, Dr. Jim?
Yeah,
there
go
we go.
ahead. Go ahead.
Hi, Dr. Brad. Thank you very much.
Oh, sure.
Thank you very much for giving us this very informative lecture. You didn't hold back with any of the information, and that was so helpful for us. Thank you very much.
Oh, you
So
bet.
my question is, whenever you do the hydrodissections, do you follow up like a week after and you do another session of it if needed? That's my first question. I'll ask the second question after.
Not necessarily in a week, but within 2 or 3 weeks is kind of my goal to make sure we follow up. But definitely there's repeats in a lot of patients. And I haven't been doing the the serrati fascia hydrorelease for very long, because Philip just really started thinking it through about a year ago, and he's done a lot more than I have. He moves quicker than I do in the office. I'm pretty slow, but that's because I want to be academic all the time. So fortunately, I have a practice where I can do that. It's taken years to get there, but anyway, so I do a lower volume and spend a lot of time.
Dr. Brad, whenever you do, there was this case that you presented earlier where you injected first and then you adjusted the needle deeper. Did you have to take out your needle completely and then, or just move it a little bit still inside within the plane?
Come into the sub-Q and redirect. It's generally tolerated the best, and then you don't have to go through. Although when I'm doing ultrasound guidance, I always use skin blebs, numbing at the skin, because then patients don't jump and alter your needle course. Sometimes I'll actually then do a little lidocaine with bicarb into that first layer of the fascia too, so that as you go through that, people don't jump. But usually once you get through those, then it's not too painful, right? So.
Thank you, doctor.
Sure, you're welcome. I like the koala picture down here. This is good.
Can I just ask just one question? Did you see any pathology? You were showing us a shoulder thing with the patient. Did you check the shoulder if there's any pathology right there before you?
On him, on that particular patient, I don't think I've looked. I can't remember doing an ultrasound on his shoulder right now. But like in one of the references is a chapter from an orthopedic text that I did a couple of years ago. And one of the examples in there is a 15-year-old swimmer who had rotator cuff bursitis and tendinopathy, 2 years of progressive pain, unable to swim. And with her, she clearly had pathology, and we have dynamics of her impingement, kind of the subacromial bursitis and impingement. So she had like a middle-aged person's disease at 15, right? But what hers started with was a badminton injury. 2 years before she had seen me, she was playing badminton left-handed, and she threw her arm out like this to hit the little birdie, because it was going past her, and she felt a pop as she threw her arm off her body. And the pop was right at the medial border of the scapula, and she had torn at the junction of rhomboid minor and rhomboid major as it's feeding. And she also had the fascial plane, the posterior layer leading down to the thoracolumbar junction, also was unorganized. So literally, I think of it as her throwing her arm off her body because she wasn't coordinated enough neurologically at that age to control it, right? She's kind of clumsy. And so all we did was treat the fascia at the midline where she was tender, and then at the scapula with dextrose several times. And then all of her impingement stopped. So I never did anything directly here, because once we stop the impingement, it's probably going to normalize. And she's actually, I think she's in med school now. It's been quite a long time. Last I heard, I know her mom a little bit, and her mom said she is thinking about being an orthopedic surgeon. So anyway, it's so again, you don't treat the pathology, right? Like Dr. Vuong said in her lecture, right? You don't treat the image, you treat the patient, right? So I can find ultrasound of abnormalities in every middle-aged person that comes in the office, right? I mean, if you do ultrasound, right, you could look at one elbow that's symptomatic and then look at the other elbow, tennis elbow, and go, well, the left one looks worse, but they're having no symptoms there. So, right? So for me, with these complex chronic conditions, I want to see a history that makes sense with the physical exam that makes sense with the ultrasound. And then if all that lines up, then the PRP should make a big difference. the dextrose prolo should make a big difference. And then once you get that feedback from the body, then you really know, okay, I got the whole picture.
Good to know. Thank you, Dr. Brad, for your wonderful time with us, and we hope to see you soon
Yes.
in person.
Oh, that would be fun. That would be fun. I've loved my travels in Asia.
Right.
Prior to Hong Kong, I'd never been to Asia. So Hong Kong,
Yeah.
Taiwan, Australia. Now we got to do Philippines, right?
Right. So thank you, and I hope you be safe wherever you are.
Yes.
And always make sure you're in the best of health.
Yes,
So-
you too. You
so
too.
Yeah, thank you. And so we can see you soon. So
Yes.
we will be posting your lecture in our YouTube channel for everyone to see as well. Is that all right with you?
Yes. Yep.
Okay.
We got to get the word out, right? I would love to hear feedback from people if they find similar injuries.
Definitely, Dr. Brad. And this is a very good addition to our management, because sometimes we just really look into the injury and then we forget to do the dynamics of it sometimes. So this is very good. Thank you very much.
Oh, you're very welcome. My pleasure.
Dr. Jim, are you still here?
I think he got disconnected.
Yeah. But it's very good to be connected with you right now, Dr. Brad. Thank you very much.
You bet. So I guess I sign off. Yes.
Yes.